As you all agree that sepsis has been a problem despite our preventive abilities and interventions. Coming to the scope and the Indian statistics, as you see, Indian data is obviously much less on the sepsis, but day by day it is increasing, and this is by Dr. Tori in critical care in 2010. What is in our country? Total admissions 86%, and various parameters, you can see various attributes which are there are much different than the Western kind of literature what you must be seeing. And based on that, he had some conclusions that severe sepsis is also common in Indian ICUs, and the mortality, by whatever reasons, is obviously higher than the Western literature, at least reported. The gram-positive infections were less common than the West, which they report in much higher quantity. Incidence of parasitic and viral infections, which obviously are less in the West, we are probably more, we have common with us. In 2010, Indian Journal of Critical Care Medicine, the volume in the beginning, you see this another paper by Dr. Tori, which is an editorial by Dr. Tori, and in that he has seen that there are 3 papers, which is original work on by these respective people, and there is emphasizing the importance of sepsis, and that particular journal issue was on sepsis only. There are different categories of patients which will come in, and this is one category where old and very, very old patients, which are very, very vulnerable to sepsis and sepsis related problems, obviously have a different statistics than the younger lot. So this is one presentation which was done last year, and this is a study particularly in the elderly patients. Over 20 months, it was found that sepsis was found about 387 patients, of which 132 had a severe sepsis or septicemic shock, probably with other failures. Commonest suspected site was lung, which is, I think, true for most of the places, and other ones less common, that is urinary tract infection, abdomen in lesser percentage. The mortality in younger patient was obviously less, that's 45%, and that to very, very old patients up to 79%. So the conclusions were there is increased need for organ support in old and very old population, which is logically sounds very correct. The risk of dying from severe sepsis is considerably higher in the old and very old subgroup of patient, and probably aggression is needed in recognizing as well as intervening these particular syndromes. Another category is a post-operative sepsis. We probably have less literature on this, and few things are definitely obvious from this recent paper in Neurology last year. The severe sepsis has gone from 0.3 to 0.9%, as you can see, but sepsis-related mortality with some interventions probably has gone down, and that is improvement of 44 to 34%. And obviously the costs, which will obviously be varying with us, and they are also on rise in our country as well. Second, this paper shows that sepsis response team, we have been in attempt to find out what are the various ways we can improve the sepsis related survival, and like guidelines we will talk about later. This is one concept, that sepsis response team, with such team having some concerns, urgency, aggression on their part, and information recording going on for a particular period of time or constantly, probably has some impact on the survival, which is due to sepsis, related to the sepsis. Daily screening with feedback, and this response team decreased mortality from 30% to 28% and 22% effectively. Margin may be significant. The compliance of all elements of sepsis resuscitation bundle improved from baseline 12.7% to 13.7% and 53.7% respectively, which is a very, very significant improvement. Another issue is related to the approach by which we stratify this particular group of patients, and predisposition, infection response, and organ failure. That is PIRO approach we've been following for stratifying these particular patients, and probably it might have some impact on this, and there's a lot of investigations going on this. This particular study provides that evidence-based support for the PIRO approach to sepsis staging is probably has some impact on this. Coming to biomarkers, which is a bigger area, and this particular area is, I think, a lot of research is on, and in this particular area, you can see there is a galaxy of biomarkers which are there, and we probably have few of them which might have been investigated with us and may have some kind of a positive impact on the improving the sepsis related morbidity and mortality. The older ones like C-reactive protein have been found, reliability of which is in question, and something more like troponin T, etc. are coming in. Procalcitonin, we have been using it, and there have been contradictory results in this. Pentraxin 3, which is one of the promising ones, is coming and probably taking place of, will be taking place of few others in future. And NGAL and which are related to kidney injury specifically probably will come in picture in distant future. And there was a separate lecture on this particular topic. This one which we are using particularly for myocardial infarction patients also found in related problems, and calculating highly sensitive cardiac troponin present in patients with severe sepsis and septic shock associates with disease severity. So there is a marker available probably or maybe available in future that severity will be depicted by particular marker like troponin T, and it also has an ability, probably it might give us an earlier indication that something is going wrong or morbidity is likely to be more. Regarding procalcitonin, I think a lot of literature has occurred, and you can see all these papers with a lot of comparison whether there is a pulmonary sepsis or not. We have radiological and clinical evidence. There is a doubt about the infection is there or not. It happens obviously in pancreatitis, meningitis, and of course all these fevers of unknown origin. There has been some help by procalcitonin as far as diagnosis of this particular condition goes. Therapeutic advantage also been found to its credit. So PCT guided antibiotic therapy in critically ill patients and days of antibiotics is one paper, and previously there were two papers supporting the same, which show that if you go by PCT guide as for the days of antibiotic or limiting your antibiotic therapy, there is some impact on improving the requirement of antibiotics. There was no improvements in mortality, at least the number of days antibiotic a patient probably will receive. So what is the, it is used by many people rather aggressively. People like me probably use it very, very conservatively. The cost is, we have some can be helpful in appropriation of the therapy. Obviously, detection of new infections, it is sometimes helpful. The exclusion of diagnosis of sepsis probably may be there. Duration of antibiotic the outcome was found whose PCT concentrations decreased with 50%. Medication does come with procalcitonin. There has been a controversy, but or positive direction probably it might help. PCT kinetics probably were not following much, but it could offer an individual risk assessment in patients with same patient with levels. This is a newer one, and pentraxin 3 is another mediator released by various cells, and its levels probably to about this. And there was a paper in ICM in 2010. This particular paper did have some positive things to be said about this. Persistent high levels of plasma pentraxin 3 over first 5 days from diagnosis are correlated with poor outcome. So if you find very high levels, obviously it is predictor of a poor outcome, and it also has some correlation with the disease severity, and probably it needs further investigations. Even if it comes in, obviously there are various issues when any new particular biomarker or new particular agent coming in, and we have natural kind of attributes which we looked into that. The natural half-life, the time course of its expression, the impact or its impact in the sterile inflammation where there is no as such infection, the indigenous organ failure and its correlation with its levels, and other effects in the body, all will needed to be taken into consideration before actually really use this. NGAL has been coming in, and plasma levels, though not very, very useful, probably urinary NGAL is going to probably give the idea about the acute kidney injury which is related to sepsis. So it is found to be much higher in sepsis related kidney injury rather than other kidney injuries. John Lee had this particular presentation in last year's ICM critical care. So he had reviewed so many Biomarkers have been reviewed in so many references and so many studies which were done before. About 178 biomarkers were reviewed. It's a huge kind of exploration, of which more than 170 different biomarkers have been assessed for their potential use in sepsis and probably the prognosticating the related problems. None has sufficient specificity or sensitivity to be routine into. This is a very important statement, and a lot of probably research work has gone into this, and then the conclusion has come. So we probably have to look for something better, or maybe the existing ones need to be properly reevaluated, and or combination of few others may be helpful put together. Toll-like receptors, and this is a probably rather new concept, but these receptors are existing there, and they have their own role in mediation or chemomediation of sepsis or sepsis-related inflammatory process. They are also being targeted, and there is a therapeutic angle to that. We'll come to that. This particular paper shows that they can be activated through other mechanisms relevant to the pathology. The regular mechanisms which are explained in case of sepsis. These particular receptors are on the cells, and this endotoxin, which is like polysaccharide endotoxin, it gets attached to that and it increases the other chemical. What is the therapeutic angle to this? And the eritoran, which was investigated extensively through the trials, and it was found that this antagonist or toll-like receptor 4 antagonist might have some benefit in the therapeutic intervention, and that's why this particular agent was experimented in animals followed by in humans. And the phase 2 trials probably showed some promise, but subsequently the phase 3 trials probably did not show much, and in phase 2 trials you could see that there was some benefit seen, but subsequent recent literature which is reported this year only and phase 3 study of this particular agent have failed to reduce mortality in severe sepsis, and obviously the hope that it would get launched and might help in some way what APC has probably done to some extent, but it was not the case to be, and this couldn't be coming in. So that's about that agent. Maybe in future similar agents may get tested, and hopefully we'll get some kind of breakthrough in similar kind of agents. Less is talked about immune response, and immune response is one such area where sepsis probably has something much common with, and immune stimulation in severe sepsis has been a theme of this particular summit there, and there has been enough kind of discussions and literature available on this now, which has its own importance because therapeutically probably this particular method is going to have some better kind of a positive impact on sepsis and survival due to related problems. We all know that immunity has something to do with the response by which the sepsis manifests, and after the innate immunity of the person is probably compromised in the due process or the ongoing process of the sepsis, the adapted immunity probably lasts for some time, and those people who cannot return to homeostasis or normalize ultimately lead to a death, and this happens more commonly after 3 to 4 days, and it is seen that 3 days probably is the period beyond which these sepsis deaths are more commonly seen. Now there are markers by which we can measure whether the immune paralysis in the body is taking place or not, and MHLA-DR probably is one of the marker probably seen development. So early in the infection probably its expression is evident, and in case it is worsening further probably this particular expression may be more and more evident. A significant lower MHLA-DR expression was found in non-survivors. So if the levels are very low, it indicates that there is a kind of immune paralysis or immune compromise in the patient and might have a different or probably a worse outcome as compared to other people. And there have been a lot of evidence that immune compromise does take place in sepsis. Failure to clear infections, because the findings from autopsy studies consistently have shown that majority patients had some infections which were persistent, probably were not diagnosed, and that goes in in tune with that immune paralysis to some extent existed. Macroscopic postmortem findings in 235, and this is in 2009, but it probably has a significant message that 80% of the patients autopsy-related continuous septic focus was still there. So acquisition of secondary nosocomial infection with bacterial and fungal organisms that are not particularly virulent to normal immunocompetent patient are also found in, and that's probably the second evidence that this kind of a problem does exist in the body. And you all know that herpes simplex virus or some other viral infections do occur in this particular subgroup of patients where it again probably indicates some kind of compromise on immune system. There have been no direct studies on this, but there is enough reason that it can be correlated to the cancer patients where immunomodulators have been used, and this particular study in last year's NEJM, that treating cancer by targeting the immune system probably is going to be reality. And there have been some conclusions out of that, there will be extrapolation of these agents which can be utilized probably in the similar manner in the sepsis patients. Probably needs a lot of investigations, and methods to distinguish the hyper versus hypoinflammatory phase of sepsis will facilitate immunotherapy, and probably this might become some practicality later on. Interleukin-7 is another agent which is promising. There is one paper about it. I will not go into details about principles of immunotherapy. We will only say that immunotherapy probably may be found as a major kind of intervention in sepsis related management or sepsis problem related management. The same slide which got repeated. Okay. So targeting this particular, what are the actual breakthroughs in this? And there's one breakthrough at least, that GM CSF, that is which is used commonly in hematological problems, has shown some promise in sepsis related problems, and patients receiving this particular agent had a shorter length of mechanical ventilation, improved Apache score, and a decreased length of ICU, so overall indicating that it might be beneficial. And there was a trial carried out, reported in Blue Journal in 2009. Obviously endpoints were that whether it could help some way primary, and secondly obviously any other attributes to the various factors like ventilators and scorings, etc., or inflammatory marker measurements, whether they have any been changes in those, so that which can indicate plus or minus side of sepsis related problems. So this study obviously has primary endpoint that MHLA-DR expression increased to baseline levels in this particular group where they received this. That is one indication where it was found that MHLA-DR is low and is coming back to normal, probably gives a good, and there is a very, very significant finding there. Secondary endpoints, of course, mortality there was no difference, mediators probably not much of a difference in that area, but cell counts were supposed to be better, and there have been a shorter periods of mechanical ventilation. So there is and more investigations and research will lead to some kind of a positive finding there. Interleukin-7 promotes T cell viability and probably have some kind of a role in future. I'm sure literature coming up on particular area. So coming out, we have definite problems which are coming up now. In Acinetobacter, there have been a lot of presentations on this, and especially resistance to the common agents like carbapenems, etc., have really put us into a fix as to what kind of a future lies for us. This particular report in 2010 obviously had a kind of retrospective study in 200 patients. Acinetobacter omni should be considered for removal of invasive devices. So at least some message was there. Bacterium was found in more than 50% of patients, and where you find agent is this kind of microorganism is there and its resistance is documented, probably we need to be less around therapeutic intervention, or maybe existing lines, etc., may need to be coming out. A lot will be heard about this in the whole conference here, so we'll just go through a very highlighted. You all know that it was launched in 2002 after the declaration in Barcelona, and followed by all these phases. In phase 4 2010, they are going to revise this 2008, and first 15,000 out of 30,000 plus patients data is already been analyzed and published. Professor Levy in the morning said that 2012 probably the whole revision of the guidelines will take place, and about a year later probably you'll hear some difference in those guidelines. We all know what it was about, and there are bundles, resuscitation as well as management bundles with about 11 parameters to be looked into, which includes antibiotic, vasopressor, steroids, and so on. So these had definite impact on this, and 2010 in February, both the journals had these details coming up, and this particular data was analyzed and reported last year. There were many various kinds of promises seen in this, and probably there have been positive impact, and this particular guidelines are likely to help, though there was a criticism, and in the debate in the morning you must have heard that maybe the people who are very well trained probably use less and less. I think everybody is intelligent enough to understand what the utility will be. So probably at individual ICUs and individual levels, these applications will go on variably. It definitely has, and as the literature tells us that there are some factors which improve the mortality in that. So definitely broad spectrum antibiotic had its own role to improve that. The blood cultures taken before antibiotic did guide us to have a better outcomes. Controlling blood sugar, I think there is enough reason to believe this. APC, of course, in first 24 hours, if shock was associated with sepsis, it had a better outcome. And achieving plateau pressures in ventilation obviously had a reasonable positive impact. There were factors which did not have much of a role, but maybe of concern, and we need to monitor and manage and continue to use these kind of parameters like lactates, low-dose steroids, of which there must have been enough discussion around, and CVP, and of course venous saturation has also been as a part of EGDT. We've been learning about it, and that actually stays in the as a part of surviving sepsis campaign guidelines. This was a analysis which took over 2 to 3 years between 2005 and 2008, and almost double the number of patients were, but the first analysis came with 15,000 patients from 165 hospitals. It's a huge study, and definitely have some highlights. That is, recession bundle compliance did increase from 10 to 31% over 2 years, which is a massive increase. Management bundle compliance, of course, improved from 18 to 36, and that also has a very positive impact. And mortality, of course, was from down from 37 to 30%. So that was also a very, very important kind of impact. As you can see that in initial quartile they had less, but definite improvement of 10 to 21%, and that's the really positive side of it. Individual components and mortality benefits need further probably exploration, but overall these kind bundles which been practiced or put into practice definitely helped. We tried to do this study in our country, and mosaics, many of you must have been the part of this study, which was carried out in 2009 under the guidance of Dr. Yang-Suk Ko from South Korea. Jason Fua and they reported it as a poster in last conference in Europe, and these were the findings. That you can see that our compliance probably to these bundles is much poor, and you can see that lactate measurement hardly 40% people we do about it. Even the antibiotics, which is probably the most effectively which can be done, even that is not happening. So other parameters obviously you can see it again, and about APC, of which also role we'll talk about it, obviously is very poor because of probably the cost effectiveness, etc. So our compliance is far from what it should be, and it's up to all of us that we take up these guidelines. And probably Professor Jean-Louis didn't agree because he had different approach. We probably need these guidelines much more, and we all have to be little aggressive in following these guidelines so that we change our these statistics to much better maybe in due course of time. And the conclusions obviously were that the most appropriate strategy to improve outcomes in severe sepsis may be to concentrate on ensuring early administration of antibiotics after blood cultures and appropriate fluid therapy. Even that is not happening with us. So let's take it up from that and try to go on with little more aggression. I won't go into details about these parameters because there have been of concern. Lactate was not a factor which really changed the outcome, but it does have, the recent literature is coming up, and people are talking about its measurements and management probably as a guide to decide about oxygen delivery and septicemic shock improvement. Its clearance obviously has some positive aspect to that, and quantification is on, and I am sure that many papers will appear in due course where the quantification or clearance probably give us the idea at how aggressive we need to be in the management of shock. Early antibiotics obviously is logically correct, and there is no doubt as soon as possible, as Professor Jean-Louis said in the morning. So no time related definition to that, but as early as possible. But other points about them are, if by chance you have to give, happen to give the inappropriate antibiotics, the increase in mortality is at factor 5, and that is quite scary, because inappropriate antibiotics is not an uncommon thing with us, and which might have such kind of bad impact that we need to really be careful to choose the antibiotic appropriately. The second aspect of antibiotic is inappropriateness, shown in this paper, that initially inappropriate antibiotic therapy occurs in 1/3 of the persons with severe sepsis. So 30% people get wrong antibiotics, and obviously there is a problem there. Beyond its impact on mortality, initially inappropriate antibiotic therapy is significantly associated with length of stay in this population. So obviously that has its bad consequences as well. Third is regarding combination of antibiotic, and combination antibiotics also have probably shown that there can be a problem with this. And early combination of antibiotic therapy is associated with decreased mortality in septic shock. Maybe some prospective studies will be needed. This particular paper, though it is retrospective and was a multi-center cohort study with a huge number of people, about my patient about 4,000 plus, and it has its own result. You can see that the intensive care unit mortality had decreased. The hospital mortality also was seen less. Ventilator-free days obviously were probably it is significant change there also, and of course inotrope requirement was also seen. So what I see, if there is a antibiotic combination which is wrong, it can have its bad impact. Nothing to talk much about this. It's well established thing, and few parameters from this were obviously taken into SSC guidelines as well, and I think we all know about this. But one important thing about venous oxygenation is that this is a recent one, that is 2010 in Annals of Emergency Medicine, that even the high concentrations or high levels of saturation are linked to higher mortality. That is something which is it has to be kept in mind, and maybe more study will be needed in this. Low as well as high, both are going to be detrimental. That was about SSC and related problems. Comes from hemodynamics, and a lot of work is in this area is also being on, and Professor Takala obviously had a concern that whether we should target the blood pressure as a figures, and in sepsis, is that the only thing, or we need to something more. And this review article obviously dealt with many things. There is a lot of variation, and his concerns were obviously because of there are a lot of variation in the target BP which people think about, which is correct for a particular patient. And probably the optimization of vasopressors is not occurring, and that is the concern, because there is a bad side of vasopressors. In case you are giving high exposure or undue exposure to vasopressors, probably it has its own impact of negative side. Possibility of better outcomes with lowest effective BP target probably is looks like a logically better concept, and probably need to work on this in a different or better manner. Well, where advances are there, and we have been using this ultrasound for measuring the intravenous, the inferior vena cava diameters with variation in the respiration, etc., and something called caval index. It's also being used, and it has its own impact. It's transabdominal approach, AP diameters, and taken with the various phases of respiration, that is expiration and inspiration. There have been positive things about this, and this particular paper came in annual meeting in Arizona. Talks about the three different people have talked about positively about this, and it does help in fluid management in sepsis, where they have tried to quantify its benefits in different manner, and I think it's going to be one of the useful tool in fluid and shock management in these patients. There have been evidences that alternative technology, which is mainly non-invasive, and we are trying to be more and more non-invasive, has its own impact on continuous as well as moment-to-moment monitoring of hemodynamics there, and this kind of esophageal Doppler, etc., probably will further add to the precision in the improvement in the management of hemodynamic parameters. Well, this came in recent, that is 2011 in first issue, I suppose. Arterial pressure-based cardiac output monitoring, multicentral validation of the third generation, and again, John Louis had this kind of validation done from compared to second to third generation, and their conclusion obviously that the flow track of third generation is much better as compared to second generation. Taking a combination of parameters or combination of factors obviously helps everywhere, and here also the cardiac output with CVP together, I think, had a much better kind of impact on the hemodynamic monitoring. Well, about IV fluids, we all talk about fluid challenge, etc., and there have been various studies regarding comparing crystalloids and colloids, and obviously there have been variable kind of outcomes from the studies. Synthetic colloids are without super effect in clinically ill adults and children, but must be considered in harmful depending on the cumulative dose administered. So nothing is really good about colloids as such. There are studies about albumin which will be coming in, but there is not much of a difference even with the recent literature says this. This particular study was in pediatrics, but it's a big study again, reasonably 1,000+ patients. has some interesting finding. It did not identify sufficient evidence to inform the preferential use of either colloids or crystalloids in treated pediatric patients. So there is not much to be chosen between two. Albumin, there have been studies where we all know about from safe to now. There was a finding that it is at least not harmful. That was tried to be proved that it is not harmful, which has been incriminated in certain studies. So, but no harm doesn't mean it is indicated again. That has to be taken with little caution. And just because it is not doing harm, probably people might start using it in more quantity, as it is been little abuse of this particular colloid. And probably there is a caution in this, that in this meta-analysis which was done, albumin-containing solutions for the resuscitation of patients showed lower mortality, but it has to be taken with the caution. There have been a clear guideline about PCV transfusions, and there has been a warning that excess transfusions can also obviously be harmful. And what we need to look into that, there has to be a proper guideline is to this. We are using 7 to 8 grams % as a cutoff point to have the red cell transfusions being given. Excess transfusion obviously was associated with worsened clinical outcomes in the septic shock patients. A lot has been talked about this. There is a pressor, vasopressin, and that too with steroids, etc. In combination also have been tried, and ultimately in corticus, obviously there was a caution that no difference in overall 28-day mortality rate, though it has been recommended in other guidelines. And together also they probably have a difference of mortality, but probably not statistically significant. So this particular area probably needs to be worked on more. Of course, this particular area is again going to get discussed. There was a separate session on this. People have been trying to do meta-analysis about this, and by Bayesian approach, probably people try to look into all three meta-analysis together, that there were no benefits. So probably at this moment we have to be obviously had this particular things to be shown. Based on results of NICE trial, it is clear that attempts to normalize blood glucose with IV insulin during critical illness results in higher rates of hypoglycemia. So by applying insulin administration at particular point, probably you need to be careful, and the cutoff point taken probably needs to be changed. We are not very sure about this. Regarding glycemic control, there have been recent papers coming in, and in order to achieve optimum benefit for our patients, clinicians must manage all three domains of, three domains are these levels, the glycemic variability. There was a representation on variability just now by Dr. Todi's student, and which showed that variation is really associated with a bad outcome. And hypoglycemia, of course, it has its own impact on the negative outcome. So there is now a large body of literature that demonstrates that these goals cannot be achieved with intermittent monitoring of glucose levels, and this particular study tells that there has to be a continuous or near continuous glycemic monitoring. Now how to do that, probably we'll have to find out in the newer technologies. In inflammatory responses, obviously a lot has been said about prowess and everything, and I will not go into details, but last statement which I thought in Cochrane review in that literature is seen coming up with a positive impact. That particular literature line was, unless additional RCTs provide evidence of a treatment effect, policymakers, clinicians, academics should not promote the use of APC. So that's quite negative about it. But though it is said like that, it has been effective in a selective manner, and probably a non-serious trial also showed that it has the caution about bleeding risk. The pediatric population, obviously there has been a negative side to that, and of course in certain small subset of this is another recent trial, that is refractory septic shock, and the probably had some better outcomes. This is without problem, and I think we all have accepted this. So this is a controversial area, and maybe some other work is needed in this. Impact of surviving sepsis campaign, I am not going to say it again because everybody is aware that there have been some criticism on this also. But I think we'll leave it to that, and we accept that the guidelines will be useful for people, majority of people in India, because there has been a variation in training and the competence. Acute kidney injury, a lot of has been said about. This is one paper, and particularly I quoted because it is from our own journal, and there has been good relation between acute kidney injury secondary to sepsis, and it is there, has distinct pathophysiological identity. Biomarkers, we were talking about it. I think we'll get some idea that something will come to rescue that early detection, and some preventive strategies might be planned depending on the biomarkers. The new concept obviously in this is hemoperfusion, and polymyxin B hemoperfusion probably is coming in. There has been little concern about it. It has shown some positive aspects, and our own journal reported in October issue that it's from Sakamoto from Japan. Selection of acute blood purification therapy according to severity score and blood lactic acid values in patient with septic shock. So they try to use these two parameters as an indicator of improvement, and the conclusion is that polymyxin column might be effective during the early phase of septic shock before a high level of lactic acid is present, and PMMA of course might be the most useful column for performing CVV HDF after DHP polymyxin treatment. So this is area I think is going to be a little more promising, and probably will need more work on this particular method. So this is again reported very recently, and there have been some retrospective review in this. So there is a little concern about, because its inconvenience, time consumption, and probably the cost have been shown as concern points here. That's all about major areas where we have some kind of impact coming to our way, which probably will help us in future. I think Bala Venkatesh and his team try to show that interstitium, which is the major one compartment in the body, probably has the more promising kind of diagnostic ability, and the next diagnostic and therapeutic platform in critical care this illness can be interstitium, and he had his own conclusions reported last year. Monitoring of the interstitium is feasible. We have to obviously have more devices to the mark. Can be achieved through minimal invasive techniques, has improved the understanding of the pathophysiology of critical illness, has the potential in diagnosis and management of sepsis, early prediction of organ deterioration, and finally, and obviously we have to have many more studies coming in before this is really a futuristic thought, and probably beginning is there. So I stop at that, and